hope you'll stay here for another few years, because I'm learning a lot every year from all the presentations that we're having in this course. So welcome again to the course. My talk is a little bit out of order just because of I have to leave unexpectedly early, so this was supposed to be in tomorrow's section about ossiculoplasties and tympanoplasties. But Robert asked me to give basics and principles about ossiculoplasty. And this is a very broad topic. This is a very wide topic, as you know. So we'll try to address it in about 10-15 minutes just in terms of general principles, and I think we can have a lot of discussions. But as you know, the middle ear itself acts as a pressure amplification mechanism. You know, and the main idea is as sound is traveling through air and it has to transition to traveling through the perilymph in the inner ear, there's an impedance difference, and this is the entire function of the middle ear is essentially matching this impedance difference. And this is done essentially because of the surface difference between the tympanic membrane and the oval window, which is about 18 to 19 times, you know, the tympanic membrane is about 18 to 19 times larger than the oval window surface area. And also there is some catenary effect of the ossicles rotating around an axis that's a little bit off-centered, and that gives you another 1.3 to 1.4 times amplification, which brings you up in the human ear to somewhere between 19 and 22, depending on the studies you read, 19 and 22 decibels, which essentially matches this impedance difference between the air and the fluid. Now, this mechanism can be affected by disease, you know, tympanic membrane perforations, ossicular discontinuity, ossicular fixation, and loss of round window shielding, which is something we sometimes tend to forget when we're looking at middle ear pathologies and chronic middle ears. Sometimes perforations that sit over the round window, even with an intact ossicular chain, can result in a significant conductive hearing loss just because of that wave cancellation. So the wave goes in through the round window and through the oval window now, and at some point in the inner ear, the waves cancel each other, and you get this little cancellation. So thinking of the round window, I think, is important when you're reconstructing those middle ears. Now, ossicular discontinuity, these are some general principles, you know, some general reasons. Trauma, of course, maybe it's more common in some areas than others. Erosion by chronic infections and cholesteatomas. This is probably the most common pathology we see, and of those, by far, it's the erosion of the incudostapedial joint, followed by erosion of the entire long process of the incus. Maybe next is the stapes superstructure, and less commonly we see erosion, in primary cases at least, erosion of the malleus or erosion of the footplate. Ossicular fixation, of course, most common is otosclerosis, and less common is congenital fixation of the stapes, tympanosclerosis, and other congenital fixation syndromes with malleus head ankylosis and others. So the definition of a tympanoplasty, as you probably know, is a procedure, first of all, to eradicate disease. So we're trying to clear that middle ear. Second on the list of goals is to reconstruct the hearing mechanism, and this could be done with or without tympanic membrane grafting. And we're trying to address a various range of pathologies. So it could be done for simple perforations, for retraction pockets, for atelectasis, for cholesteatomas, or for chronic otitis media. Classifications are usually, made for a reason. They're made to help us think of pathology or of reconstruction protocol in a very structured way. And we're all familiar with the Wolstein classification, and this is the Nadal and Schucknet modification of it with type 1, type 2, and different kinds of type 3 classifications. There's, of course, the type 4, and very, very rarely used the type 5 nowadays. So the goals of our approach is to eradicate middle ear disease, as we said, create an air-containing middle ear space, and then establish an intact tympanic membrane, and eventually restore hearing by building a secure connection between the eardrum and the cochlea. The functional result we're trying to achieve, so this is anatomy if you want. The functional result is we're trying to bring, as much as possible, the operative ear to within 15 decibels of the contralateral ear, because this is the magic number where patients start feeling that binaural input is really significant, that the difference between the two ears is not affecting them as much, and they can benefit from the binaural function. At some point along the way, in your surgeries, you have to decide. If it's a simple perforation, you just proceed with it immediately. But if you're dealing with a more complicated case, sometimes you have to decide on whether you need to stage or not. And this, again, is a long discussion, but it's worth putting out there as a point that, sometimes severe mucosal disease, sometimes a residual cholesteatoma will make you think about reconstructing in the first place in a primary surgery and delay it. And I know this is This changes a little bit depending on the approach that you use, depending on your experience, depending on the follow-up that you're doing, whether you're doing MRIs or you're planning to do second stage surgeries. So all these factors come in on deciding when you want to operate or not, when you want to fix the ossicular chain or not. If you look at the literature, there are actually quite a few studies that look at different factors influencing the outcome. So you have, for example, SPITE that says the surgery is important, what kind of prosthesis you're using, whether there's infection or not, the tissue health regardless of the infection, the function of the eustachian tube. Another protocol is called TRAX, which is looking at, says, the tension that you put the prosthesis under is very important. Round window protection is important. We talked about this. The angle of the prosthesis, this was just mentioned a little earlier in one of the talks, whether the prosthesis is centered onto the tympanic membrane or not, and the air-containing middle ear space, looking at a minimal space in the middle ear. And the truth is, these are probably all very important, and they vary from one surgery to another. I don't think we need to follow exactly one of those protocols or one of those eponyms, but I think all these factors are things to think of when you're trying to rebuild that ossicular chain and trying to reestablish a healthy middle ear. What are contraindications? We touched upon this a little bit when we talked about staging. The only true contraindication is probably an acute infection of the ear. And a relative contraindication is persistent middle or ear mucosal disease and tympanic membrane perforation, repeated unsuccessful use of the similar prosthesis or same prosthesis. And somewhere probably in the middle is between an absolute contraindication and relative contraindication is whether you're operating on a only hearing ear or not. And this is, again, sometimes we have a debate on this in this course and other courses. So going back for classifications to give ourselves a little bit of a framework of discussion, Austin published his classification of the status of the middle ear, and it included the classes A, B, C, and D. And then Dr. Cartouche expanded that to include that's 7 classes now, with 0 being all the ossicles being present. M is malleus, I is incus, S is stapes, and including ossicular head fixation as class E and stapes fixation as class F. So in terms of this talk, I figured, if we follow this classification, and you might use another classification just as well, that's fine, but if we follow this classification, it gives us a little bit of a framework in terms of thinking of it. Another thing we can look at to address the outcome, the factors of success, is the middle ear risk index, looking at otorrhea, perforation, cholesteatoma, ossicular status, middle ear granulation or effusion, and the presence or absence of previous surgery, which I think is another helpful classification protocol in terms of expecting outcomes and discussing with your patients, and also reminding you of what are the factors that you need to control to have your optimal outcome. This is just a detailed description of this middle ear risk index with the prognostic factor, the risks from, between 0 and 1 being the best prognosis, and an ear with a grade of 12 being a really poor prognosis for a successful outcome. So let's look at some of these different classes. So type A is an ear in which the malleus is present, the stapes superstructure is present, and the incus is absent. And the mildest form is when you have erosion of the lenticular process. When you look at that, you have a couple options. One thing we hear, and this differs between surgeons, we can use bone cement just to reconstruct this incudistapedial joint. I don't know what the experience of the speakers is in bone cement. We've heard different opinions last year. I think some people like it. I guess, Chris, you don't like it. Some swear by it. I've used it on a couple occasions. I think it really requires a lot of patience, just because you have to wait for it to settle and then solidify and just make sure you sculpt it and it doesn't overflow, but it's a good option if you have it available. Cost is often an issue for these bone cements, so that's another consideration. Alternatively, you can use an incudistapedial joint prosthesis, just a couple, not exhaustive, but the Applebaum prosthesis, the Silverstein, which is not shown here. This is another prosthesis, I think, from Kurt's company, which bridges this incudistapedial joint when it's eroded. If there is more erosion of the lenticular process, sometimes you can use incus repositioning. This is one of our cases where we sculpt the incus. We do a little notch here for the malleus handle, a little groove for the stapes superstructure for the head of the capitulum of the stapes, and we position it up here against the malleus with pretty good outcomes. So that's another thing to consider if you have a remnant incus that's healthy and that doesn't have disease on it. And eventually, probably the standard answer is a TORP, a partial prosthesis that sits on the stapes superstructure. I put TORP between parentheses because I think Dr. Vincent will discuss his preference for TORPs in these situations, but most of us will probably go for TORPs for partial prosthesis. And then one thing to consider, in choosing between these different options is the relationship of the manubrium in relation to the stapes superstructure. So, people talk about a favorable relationship, unfavorable relationship in terms of the anterior-posterior displacement of the malleus handle. So it's another thing to look at when you want to decide between a couple of these different options. A type B is where the same as type A, but stapes superstructure is absent. So if the footplate is mobile, you can just use a TORP and protect the footplate with some perichondrium or connective tissue graft. You can connect it to the tympanic membrane, like it is done in this schematic here, or you can connect it to the malleus itself, and you have different prostheses on the market for that. You should usually cover it with cartilage, but again, it depends on what prosthesis you're using. If it's a hydroxyapatite, theoretically, you can get away without covering it, but I prefer to cover all my prostheses with cartilage. I just don't think there's a reason to take risks on those. You definitely have to cover the footplate at least with perichondrium, or at least some soft tissue connection, fascia if you have it, if you don't want to go and get perichondrium. Some recommend securing it to cartilage. I don't necessarily do that. I don't think it's a must. I think nowadays with most prostheses, eventually there's a little bit of adhesion that forms between the cartilage and the prosthesis and stabilizes this prosthesis. The other question is, do you use or do you not use the cartilage shoe? I don't use it. The literature, there are many studies on this, but most studies don't necessarily show a significant advantage to using the cartilage shoe, as long as you're respecting some of these other principles in terms of proper length, proper tension, proper centering of the prosthesis. I personally, and that's a personal opinion, I don't think it makes a huge difference whether you use a cartilage shoe or a footplate shoe, which again adds to the cost of the surgery. If the footplate is fixed, it's a little bit more of a dicey situation. You can still do a stapedectomy and cover your oval window with a perichondrium. Then you might want to think more about securing the lateral end of the prosthesis to avoid displacement in the vestibule. Sometimes just packing the middle ear with gel foam will temporarily hold this prosthesis out. But again, you got to be very careful. Another option, if your malleus handle is present, is use a malleostapedotomy prosthesis. There are a couple that are available on the market. So it's longer than your typical stapedotomy prosthesis, and then it attaches straight to the malleus. Of course, it requires elevating the tympanic membrane of the distal half of the manubrium. And finally, in type B, if the head of the malleus is fixed, you can probably, you have to think about amputating it. Not probably, you have to think about amputating it. Type C, now it becomes a little bit simpler. It's where the malleus is absent, incus is absent, the stapes superstructure is present. You can go to a classic type 3 tympanoplasty with or without cartilage, or probably the go-to answer right now is using a partial prosthesis. This is a polycell prosthesis that we use. It's called a Sheehy prosthesis. It's very easy to cut and manipulate and size, and it's pretty cheap to use. Of course, you would have to cover it with cartilage, as we're doing here. Or alternatively, if the malleus is absent, Robert will tell you that he will use a malleus replacement prosthesis, and then that brings him back to a type A situation where he just has a stapes superstructure and a malleus present. Type D, you could use the type 4 tympanoplasty if all the ossicles are absent. Alternatively, and I think that's probably what I would do, is use a TORP prosthesis to bridge that gap and gives you a little bit more of a middle ear airspace. Ossicular head fixation, you just separate the incudiomallear joint, I remove the incus, amputate the head of the malleus, and then I go back to a little bit of a type A situation. I use either an incus or interposition, incus repositioning, or a partial prosthesis. Type F is the stapes fixation. We've talked extensively about that. So in summary, I think really it doesn't matter what kind of prosthesis you use. I think it doesn't matter which approach. I don't think you should have one standard approach. I think you should have an approach that's tailored to every different situation and every different patient. But you have to keep in mind the fact that you need an intact tympanic membrane, you need an aerated middle ear space, you need a mobile stapes footplate. Ideally, this is a better outcome. If you can preserve the malleus handle, I think the literature has proven that you get better outcomes in terms of hearing. And then you can pick the ossicular prosthesis depending on your budget and what you have available in your market. What you use in terms of grafting, just again another discussion, but whether you just use tympanic fascia, perichondrium, whether you use cartilage or not, eventually does not have much of an effect on the outcomes on the hearing outcome of your surgery. So in this study, for example, Dr. Merchant and his team varied the thickness of the prosthesis in the lab, between 0.01 and 0.5, so almost a 50-fold thickness. And they saw, again, in the lab, no significant effect on hearing. And there are quite a few studies in the literature about that. The prosthesis, you see, I think this slide, the fact there are so many prostheses and so many materials available tells you that there's not one ideal prosthesis, all due respect to prosthesis companies, but I think it's just really what you're comfortable with. And these are just some studies. We're not going to focus on the number, but you see the numbers vary significantly from one group to the other using the same prosthesis, or they're similar using different prostheses. So it goes back to surgeon preference and surgeon comfort. These, for example, are results in 10 patients using just the Incus repositioning, pre-op airborne gap at the 4 frequencies and post-op airborne gap. Again, this is a really good outcome by all standards. So there is no single prosthesis that makes a big difference, in my opinion. So now what? I think we just answered that. Just, again, control all these factors and then think methodically through the process, and you will be fine in probably more than 90% of cases. Thank you. Questions?
Thanks very much, Mark. Okay, anybody? All completely stunned.
What happens, what's your basic technique for when you have a medialized malleus, where the malleus handle is very close to the middle ear?
That's actually an excellent question. If the malleus is medialized, I try to lateralize it, and I do that by first sectioning the tensor tympani tendon. Sometimes you do have to amputate the head of the malleus. Eventually, you can move it up, so you just do it gradually, step by step, so you keep some level of stability in terms of the suspensory ligaments of the malleus. So first to go for me is the tensor tendon, and then eventually I amputate the head if I need to, and I just keep the the manubrium of the malleus, and then go from there. Sorry.
I was just going to ask you, just curious, why you feel, and maybe others also feel, the need to use the perichondrium on the foot plate. I don't usually. I don't know what you guys feel about, putting a prosthesis directly on the foot plate versus, you said you use perichondrium on, yeah. I've been using, I put it bare bone on, and in fact, I'm always concerned about that connection between the prosthesis and the foot plate, particularly in the D when there's no ossicles to hang your prosthesis on. So that connection is always tenuous. And just for me, I think putting another layer there for me makes it feel like there's even a worse connection. I will use a shoe sometimes, but not all the time.
Well, I think because in these cases, from my relatively limited experience, is the foot plate is already thin because of infection. It's true that you rarely have a completely eroded foot plate, but the foot plate is already thin, and I just feel more comfortable putting something to cover it and prevent medialization of the prosthesis into the labyrinth. So, sorry, were you going to follow up on that?
So you're not using it for stabilization, you're using it to prevent it going through the foot plate.
Correct.
To strengthen the foot plate.
Well, it does add some stability to the prosthesis also, but that's not the main reason I use it. I just use it because I feel like I need to protect that labyrinth.
I use the Omega Connect, the little shoe. It's got a little ball joint that the torp sits on.
Yeah.
And it undoubtedly makes it more tricky. And I don't know if those of you who've used it, a tiny bit of fluid on your instrument and it sticks and it flips and it folds over and whatever. However, when I've looked at my results, it does seem to improve them a bit. So I think it has some use.
Well, Neil, I actually didn't use to protect the foot plate, and then I had this one case, of course, it's the one case that changes your practice, where the foot plate was thin and I put the prosthesis in, and I don't know what happened. A couple hours after surgery, patients started getting dizzy. CT scan shows the prosthesis is halfway through the vestibule. So since then, I just cover everybody.
Well, you may get that, or you may get a micro crack.
It might, exactly.
It all depends how your patient's managed as well. I mean, people do stupid things to their ears post-operatively. The curse of the Q-tip.
Yeah, I had a case like that with a patient who was dizzy post-operative, and I was there as a visiting surgeon, so I didn't follow the patient up, and it was a long and awful history, and eventually the piston was removed, and it was through the foot plate, and then the patient was still dizzy. He ended up getting gentamicin and getting a dead ear and intractable tinnitus. Horrible story. But I wondered what I didn't recognize at the time. I was being watched by lots and lots of people, and when I put the piston in, I clearly didn't put it through the foot plate. You know, I definitely didn't put it through the foot plate, and yet it went through the foot plate. So was it negative pressure and it medialized and went through the foot plate? Was it with the packing, you know, when I put the drum down and packed the ear, or with a bandage, or did they press on their ear? So I don't know what you think. Your patient was immediately dizzy post-op.
Right.
And I'm sure you didn't deliberately shove it through the foot plate, and you probably would have seen that. So presumably it's at a stage after you've put the drum down, I guess.
It almost certainly was, because I'm very picky. I'm very obsessive. I double-check the prosthesis like probably 20 times before I close finally. And I think it was possibly packing the ear canal, even though I pack it with gel foam, so there's not a lot of forceful. But it must be at that level when it went through the foot plate.
And the other thing is, I mean, I've seen patients post-op with a CT scan where the piston is clearly in the vestibule,
Right.
but they maybe have good hearing. It's acting almost like a stapes prosthesis.